Hello, everyone. Thank you so much for inviting me to this conference, and I'm very honored to share the stage with Dr. Dworetzky. When I was first working at the VA, I went and saw her program. It was like, wow, that's a really beautiful way of caring for our patients with FND. So I'm going to share my slides now. And hopefully everyone can see that. Wonderful. So my name is Dr. Saxena. It's great to be with you all. I'm an adult neurologist by training, and then when I went into the field of epilepsy, I developed an interest in patients who had functional seizures, in fact. So these are my disclosures. I'm also an employee at Biogen. So we're going to talk today about two cases, and we're actually going to invite back our Dr. Dworetzky as a discussant for both of these cases. So we'll hear a little more and touch on some of the points she's already highlighted. And the cases today are cases that I've seen in my clinic, and they're both, I see pretty much adolescent upward. I don't see a lot of young children because I'm an adult neurologist by training. And they highlight, I think, some of the core management pieces that we want to focus on when we talk about treatment. As Dr. Dworetzky has already pointed out, the mainstay of treatment is still psychotherapy. So as our first case is going to show us, how do you start building that alliance before you even talk about what treatment is? So this is a young woman who's actually, when she presented to my clinic, she was 19, and she had no pertinent post-medical history. And that's important to note because she started to present with these generalized shaking episodes. And when she was eventually brought to the clinic, she disclosed that at first this was staring episodes. She had just started a freshman year of college. It was away. So she's a Massachusetts student who had gone away to school, I believe in Arizona. So she was far from home. And she was losing time. Class would begin, class would end. She wouldn't really remember what was happening in class. And she was started on anti-seizure medication. So she was already given a diagnosis prior to any workup, I will mention that, and told, okay, these might be seizures. And there are epilepsy syndromes, as everyone in this audience is probably well aware of, that can be diagnosed very similar to this time frame that she's presenting with these new onset episodes. The events continued and they got worse. And so she decided to leave school. And this was a discussion between herself and her mother. And they decided, let's leave school, let's come back home, let's try to figure out what's going on. And events just continued to increase. So now she's home. There's no school pressure. She has a good relationship with her mother. And she's having longer episodes that have greater motor features, similar to what we saw in the videos that were just shown. So she's brought to an emergency room finally because of these continuous generalized shaking events. And what we find out when she talks to people in the emergency rooms is that, sometimes I can hear everyone around me. Sometimes I can talk to people around me, and sometimes I can't. And they're able to see that in that time. And so they order a video EEG, and she was very lucky in that they were able to do this test. She got admitted straight from the ER. They did this test. They were able to capture these events, and they were able to remove her anti-seizure medication. And then she was discharged. And so there's a time gap between when she's discharged and when she comes to the clinic. And I can tell you that one of the first things almost that comes in when she comes through the door is, her mom saying, well, what are we supposed to do now? We were just discharged. She's saying, can I go back to school? Because I'm not on any medication. But in there is a lot of confusion about what's really going on. So in our clinic visit, we did a long history and physical, but here I'm just showing you really what I want to highlight about her specific case. First of all, she had no epilepsy risk factors. Now, as many in this audience know, you can still get a diagnosis of epilepsy, unfortunately, or seizure disorder without any risk factors, but she didn't have any. She also didn't have any history of depression or anxiety, either that she endorsed or that she was diagnosed with. And the reason I mention that is we'll see in our social history that her parents were divorced when she was quite young, 2 years old. So this shared custody of her mother and her father is kind of routine at this point in her life when she goes to college. However, one point that changed was around ninth grade. Instead of having this split week where she used to stay with her dad because the school district was better there, she actually moved back to her mom's house. So she had to switch schools. This was in a different district. Now, she seemed to tolerate that fine. She switched schools. She had a successful college application, went to the college that she wanted to go to. But again, the college is far away. And the reason we highlight this is, again, not because these things are then why you get this diagnosis, but it gives us points of context in terms of how are we going to empower our patient? How are we going to talk about this diagnosis and then subsequent treatment with the patient really feeling that they're empowered and they're autonomous? And so you want to look for places in their life where perhaps there's advocacy, and so too places in their life where perhaps there is not advocacy. And so are these feelings of isolation perhaps exacerbated? And that's what we really talked about in this interview, especially with her mom, is we opened with, well, what are your concerns? So first of all, are you in the right place? So I introduced myself, and the first thing we get is, well, we don't really know what to do. And so that's what we talk about. And I'm going to show a slide that Dr. Dworetzky has already shown. And this is from her colleague and her group and their work, is the treatment begins from the time we're in the room with the patient. It begins by really understanding what are the concerns of the patient, what do they need us to help them understand so they can take that next step. And as I've mentioned before, that next step is really going to be explaining what we believe the diagnosis is, and then having that sit with the patient so that they can really see, does that feel right? Remembering we've just met this person, but they've lived with themselves for 19 years. And so we want to see, does this diagnosis land? Does it make sense? We want to create that sense of engagement from the time we meet them. And we really want to highlight that this is a treatment that is a collaboration. So psychotherapy is still the mainstay of treatment. And psychotherapy really calls upon the patient to show up. So we want to know, is the patient ready to show up? Is this something they feel comfortable to do? And we also want to help them understand why they're showing up. So you saw that beautiful diagram, what CBT does. We try to help understand that these can be mind-body behaviors, physical symptoms that are reacting to a way in which the brain has started to wire itself. And so we want to retrain those wirings. We want to retrain those thoughts. And I'm going to stop here for a second and just ask Dr. Dworetzky to comment a little bit on, and it was her wording actually in an email exchange recently, where she talked about how you'll see this slide is noted, treatment begins with delivery of diagnosis. And her response back was so apt and perfect. It was, well, Anita, I'd like you to remember, treatment begins when the patient comes into the clinic visit. Could you speak to that a little bit?
Yeah, I mean, especially with this disorder, where the language that's used and the movements and how you greet the patient, patients have been stigmatized and traumatized, at least in the adult world, in our medical systems. And so if they see a doctor that's rushing them, not listening, just looking at their history from a prior note, saying, oh, I see you have psychogenic, tell me about your trauma, boom, they're done. So you can really blow it. And that's why I say it's just being, mindfulness is very helpful as you approach patients. And I think taking the direct history and not relying, I tell my fellows, don't just copy and say, is this true? Is that true? Let patients speak. 5 or 10 minutes structured, you can say, we're going to give you 10 minutes to tell me why, what I can help you with today. I want to get it right. Set that tone and then really let them speak, because it's just a very challenging visit. Otherwise, it doesn't mean it will work, but I think it's critical.
I love what you brought up there in terms of setting the stage. So when we go into that clinic, it's great to set those boundaries to some degree, especially if you are feeling rushed or you're feeling busy. So your internal clock is kind of riding on your own anxiety. It's nice to also help you as the clinician to say, hey, we have 10 minutes. I really just want to open the stage for you to tell me what you think is going on. What do you understand? Just like you said, it may not work, but it at least sets the intention in the room that you're here to really hear why they're here. And that can take us a long way, especially as we know, we want to continue engagement. We want to let them know this is what we think is going on. If you need to go home and sit with that, take the time to do so. I'm here. We can follow up. We don't have to just shoot off a referral. And a couple of those pointers are going to come into our second case here. I know we're going through the cases a bit quick, but we've left room at the end because we're hoping to have a bit of discussion or questions. So the second case is a younger patient. So this is a young boy who was actually diagnosed with childhood epilepsy. About 8 years of age, he got his diagnosis. He also was diagnosed at young age with autism spectrum disorder, and he presents with whole body stiffening episodes. So his also began around freshman year, and he had these episodes of unresponsiveness. Now, he came with what we would consider pertinent past medical history, childhood epilepsy. And you can see what happened with that is the minute he started having his episodes, there was a concern that the epilepsy had returned. And so we didn't want to wait to treat that. So he was placed on anti-seizure medication. And unfortunately for this young boy, he continued to have events. They increased and they also changed. He started to have arm jerking episodes. He started to have episodes that sometimes were preceded by a quote unquote aura. So there was pain in his head, a sense of imbalance. And so throughout all of this was this chasing phenomenon. We need to make these episodes go away. They are most likely epileptic because of that history. Well, he eventually gets referred to a tertiary center. And he got the referral because the seizures were continuing despite the fact that he was on 2 anti-seizure medications. And so when he gets to this tertiary center, what we find out is his episodes now are not the episodes that he was having before. So in his childhood, he had a couple staring episodes, and he possibly had 1, maybe 2. His mother remembers he definitely had 1. Not sure if he had 2 generalized epileptic seizures. That first one just being so, emblazoned in the brain. As many of us know in this room, once you see it, it kind of just sticks with you. But they do recall that they were kind of short. Outside of that 1 generalized epileptic seizure, they were like 30 seconds, maybe not much more. They went away very quickly with anti-seizure medication. And then he stopped having them altogether, and he was successfully weaned off his medication. So when they talk to us now about what's going on, they're saying, well, he never knew when he had seizures before. There was never this quote unquote aura of pain or trouble in his head. It would just happen. So now he's getting these auras. The other thing is sometimes they think he can actually hear them. And he says, I think sometimes I can hear my mom, but I don't know. So they're not sure, but there's this, are we interactive to some degree as opposed to being totally unresponsive? And the events are long. So we just saw in the video above that length of time. When we think about an epileptic seizure, we're thinking short, but this is going on for 15 minutes. Now it may start, it may stop, it may fluctuate, but it's still this entire event that's taking up so much time. So they got admitted for elective epilepsy monitoring, meaning they didn't come to the ER, didn't come through an emergent sense. They just waited for a diagnosis, came in, and they were able to get a diagnosis of documented functional seizures. And when they came into our functional neurological disorder clinic, we find out a little more. That his childhood epilepsy began 7, diagnosed at 8, and really went away by about 12 years of age. And his autism spectrum disorder was diagnosed around 4 years old, but it's predominantly difficulty with social interactions, difficulty with childhood emotional control. And I point that out because he's really developed in school. He goes to a public high school. He has an individual learning plan. And there's been some concern over the events at his school, and there's been some bullying. But this is a boy who's really thrived despite having autism spectrum disorder, despite having childhood epilepsy. And his parents are actually very savvy and aware of how to move within the system, because they've had to do so from the time he was a young age, not just getting the individualized learning plan, but as many of you know, if a child has epilepsy, filling out the forms, the medication, making sure there's an action plan with the school that the school feels comfortable with. But here's the confusion, because now there is no clear action plan for our epileptic seizures. It's sometimes straightforward in a sense. When you get a sense of what the seizures are like, get a sense of what the danger may be to the child, to those around them, and you know what meds you can use, then you can kind of action it out for the school. Schools feel safe, families feel safe, patient feels safe. In functional seizures, though, we're really not giving any medication. Remember, we're saying that the mainstay of treatment today in 2022 is still psychotherapy. So what are we going to do? And how are we going to look at this system? And for that, I look into the family as well. Just like in the previous case, we get a sense that this is a recent separation for this young boy. Their parents have been separated for 6 months. They're currently undergoing a divorce. So that comes out when we talk a lot in the clinic. How are we going to advocate for this young boy when we want to look at everything that's going on? And we're seeing some pitfalls. We're seeing some areas where he may feel isolated within home. We're seeing some areas where there's concern in school about his events. So we're seeing a lot of places where perhaps we can't pull on strength. So we want to create a strong foundation for care. So we talk a lot about how do we pull the school into this? How do we pull his family into this? So we had a group visit. It wasn't just his patient and his mother, but we invited his father with their consent. And we actually talked about what does it mean to have functional seizures? What does treatment look like? And we talked about an action plan. And you'll notice here in the slides that we specifically had the patient create the action plan. So in functional seizures and in FND, there's a slide Dr. Dworetzky showed about around that Mark Hallett, how the brain is doing, and agency. So there's a sense that there isn't will here. These movements are involuntary. How do we help patients find that agency again? And that's one thing I try to do, no matter what the age of the patient is ask them, what do you want people to do when they respond to this? And sharing resources. You saw these resources just before. I'm highlighting them again because they're our go-to: neurosymptoms.org, fndhope.org, nonepilepticseizures.com. And so I'm going to invite Dr. Dworetzky back, and I promise you we did not do our slides together, but I love that we both were like, you have to look at the ecosystem, and I'm sure everyone in this room has already talked about that, but I just highlight this again around how do we remember our patients live in systems, and children more than most, because they're in the school system, they're under guardianship, they're under the legal guardianship of their parents or others at times. How do we create that foundation? If you can speak to that a little bit.
That's excellent. Thank you for those cases, Anita. And just as a disclosure, I had a different term, but I decided in order to dovetail with your talk when I saw your slides, to use your lovely term ecosystem. How do we do it, which is really an interesting and challenging issue without the family involved. You can't, it takes a village in medicine. And so having the caregivers of the child buy in and help, I think, is critical. It's true for the adult world as well, but you're really dealing more with just the patient. And in the pediatric world, you're dealing with so much more on a much younger brain. And that how you do this, if you do it well or you do it poorly, may really lead to a very different path. So I asked the families, who is the clinical person that you most trust? And I asked questions, and I don't know what the answer. I don't say, well, this is because you were bullied, or this is because you were divorced, because that's blaming the parents. And And you know what, I'm a parent. There's nothing worse than getting blamed for something that really is just, could be genetic, could be environmental, and we don't really know. These are just factors. So I think it's being curious, finding out, and that's where I talk about the therapy, connecting to it. This is not like on the couch, Freudian, tell me about your mother. It's really not about blaming the mother. It's really about trying to, it's integrate the patient back and finding the patient. What is your value? What do you value? If this kid valued being smart in school and doing well, and now he's falling off a bit because of stuff at home and his supports at home, and then social issues may have been a challenge. So those are things that I don't have all the answers to. I like the fact that our neuropsychiatrists, when they take the neuropsychiatric history, you can use things specific for that individual patient that they told you. Because otherwise, if you do generalities, it fails. If you say, well, most patients have this trauma, and they say, well, that's not me. And when they read about it, that just doesn't sound like me. But if you use their language, it's really much more beneficial. And that's the part of the neuropsychiatric involvement, or psychiatric or mental health involvement. But I also say that our fellows and residents and other doctors don't take good enough social histories. They like steer away from the psych history because they're taught, like, you should be careful not to use that terminology, but social history is fair game and really is a must. So I really like that you included it, and culture and spiritual. One last thing I'll say, I just read Suzanne O'Sullivan's book on, psychogenic, mass psychogenic illness. And she goes to different cultures, and it's just fascinating to me that in certain cultures, there isn't a problem with this. Even though disorder exists, it's because he's wrapped around, the shaman does something and everyone accepts it and the patient is fine. So a lot of what's happening here is the rejection, the shame and stigma from society, from the medical system, from the social network system. So it's huge, unfortunately, and I spoke too long, but that's what I'll say.
No, that was I really appreciate that point you brought up about that book, because I think I talk about that with patients too. One of the things I ask them is this debilitating for you and your family? Because, and I used to ask that thinking I'm always going to get the same answer, which I often did. And until I had a patient where I didn't, where it was like, well, this is actually our spiritual belief. And so we're just a little confused because now it's happening outside of church, or it was happening outside of, they had one of these home churches they went to. And so that became really important because it was less about treating the patient and it was more about educating the system that he lived in. And then also talking to how do you control that spiritual flow? Is there a way to do that that's appropriate within the culture?
I'd like to make one other point about the autism, because in the adult world, we do see a lot of patients with these traits. And we're all on some spectrum of some different disorder. We all have traits. And I think autism spectrum is interesting because there's focus, there's like an amplification of symptoms sometimes, is what I've noticed, which is one of the mechanisms of FND. As I told you, get an injury, all of a sudden our brains are now scanning our bodies more closely, noticing symptoms, some of which may be normal, some of, and amplified, but this never happened before, and then creates, the whole disorder going forward based on predicting this is going to happen whenever I do this. For patients whose brains are very, logical, and then you have a parent saying, no, I know my kid, and this is not that, and right in front of you, and they basically made it so that who they believe, you, who they never met before, or this beloved parent that they need in their life. And so there's a lot of challenges in the pediatric world, and often why I see my pediatric colleagues say at age 18, okay, you go see Dworetzky and team.
Right, they're like, we've held this for this long. It's now your turn. It's your turn to hold it. And it's true. Sometimes the first couple of visits are really between the clinician and understanding, how do we all get on the same page that respects everyone's viewpoint of what's going on.
So Sean,
Lori,
can I ask if they want questions from our
yes, thank you.
audience? I'd be interested in if we have any few minutes left or we're done. Be great.
It looks like there are two questions in the Q&A. I'll just fill in here. So one was from one of our participants. Is it typically neurologists or psychiatrists who take care of patients with functional neurological disorders? And how long does it take from referral to appointments in those
Oh my goodness.
situations?
I'll start with that one. So it's both, you know, and unfortunately, there's a lot of people say, well, I don't know who to send these people to because there's no, you know, there's a shortage of psychiatrists. It becomes confusing because patients get referred to me and they're looking for the they've got the diagnosis, they've accepted the diagnosis, they're looking to get treatment. And so I will sometimes do triage beforehand just to make sure they've landed in the right spot, not to delay things further. And you don't necessarily need to have a psychiatrist treating it. It could be, you know, that's why I say to people that don't have psychiatrists near them, you could train anyone, a social worker, a psychologist, a nurse. And so it's really helpful to, or a community health worker. It's just, you need somebody that will help you in terms of supporting the patient beyond just wanting to come into your office and talking medicine. And when they do come back, I invite them in, and it's usually about engagement. You know, this is currently, there will be, I assure you, there will be other treatments beside CBT and what we use at the Brigham, mindfulness-based treatments for people that feel like there is nothing psychiatric, I don't want to see a psychiatrist. But they're not here yet. And the evidence base, you know, other things are being used, but they're not here yet. You'll start to see that take off.
Yeah, I think either can do diagnosis. I think neurologists are important part of the picture for us, for our community to start owning this disease more, to be honest. So, but I think in terms of ongoing care, if you have a neurologist, and it's also about tailored therapy. So even if you have a therapist, for instance, but their specialty is not CBT, it's really asking, you know, hey, there's these resources online and my neurologist is willing to take a phone call. Can you just stick around as my therapist? Because as you saw in that CODES trial that Dr. Dworetzky showed, we saw that CBT is not the magic answer, but all those secondary endpoints a lot of them were met in terms of quality of life. So it's also about tailored therapy. Perhaps there's a different type of therapy, dialectical behavior therapy, acceptance and commitment therapy. I know Dr. Dworetzky's mindfulness-based therapy, but it's a lot more than just mindfulness in that therapy. There's a lot of other therapies that enrich it. So that team of a medical practitioner who could give you a diagnosis and anyone who can deliver therapy who will walk the journey with you, I think does it.
I'm going to take the second question is important, and then I guess it'll probably be all for us. But the time that it takes, like what's the wait, is what was asked. And so right now our systems are very stretched thin, and even beforehand, the waits can be unfortunately very long and delayed. But what I would say is that you don't need to be, the problem is you should not have to be in a subspecialist office. This is a common disorder that's in all clinicians' offices. And if you have a child that has this disorder and they're open to, you know, talk about it even in their primary care office, because that's the important person that I link in, they may have other supports. So we have to get away from, I tell, you can't just refer and not take the patient back, because I'm training that this is so common. It can't, if we took everyone, we would not be able to take any new patients. And I think that is an important point. I'm complete.